Hi, good morning, and welcome to our symposium on myelopathy. And we just heard a number of papers on patients, presenting with deformity, frailty, very, kind of severe presentation of cervical disorders. We're going to switch gears and talk about patients who actually have much milder issues, but sometimes the imaging looks kind of scary, but their clinical presentation is kind of mild. And this is a dilemma. What do we do with these? Patients? And so I'm going to ask Dr. Jeff Wang, who's also co-moderating this session with me, to kind of present a case to just kind of set us up for some of the subsequent discussions.
So I'm going to present a case that I think we've all seen in the office. These are my disclosures, which is not going to affect anything I'm going to talk about. So this is a 68-year-old female who, interestingly enough, has a past medical history of a prior cauda equina and had some type of decompression done in an outside hospital. But she presents to me with really no progressive gait issues, no change in bowel or bladder. She really just has some mild numbness in her hands. It's kind of diffuse, doesn't really follow any radicular pattern. She has some mild diffuse radicular symptoms that kind of vaguely go down her arms into her hands. And she is on exam floridly myelopathic. She's got hyperactive reflexes. She's got every reflex she tests is at least 3+ or higher. She has Hoffman's reflexes bilaterally, but really no gait disturbances. And on her x-rays, she has just some degenerative changes. She can still move a little bit. And on the MRI, she's got profound cord compression with cord signal change. And she's slightly kyphotic, which is kind of centered right at the area of the tightest compression. When you look at the cross-section at C3-4, you can see that it's mildly stenotic. And when you look at the area that's most compressed, you can see that it's very, very much compressed and has real cord signal changes in myelomalacia. So the real question in this patient is what to do for this patient. She's obviously, we've all seen this, they've come into the office and they're seeing you for a second opinion, and they said, someone told me I was going to be paralyzed if I don't have surgery. And so what do we do with this patient? I think that kind of centers around this symposium. Okay, so I changed this last night. So this is the real story on this patient. This patient is 100% asymptomatic. She has no gait disturbance, has no numbness, no radicular symptoms. She is 100% asymptomatic. She has no neck pain. Okay? On her exam, she's not hyperreflexic. She has a mildly positive Hoffman's on both sides, and that's it. So I want to retake the vote. Remember, completely asymptomatic, and it's very, very tight. There's cord signal change. How many people would strongly recommend surgery if this were your patient? Okay, how many people would not recommend surgery and just recommend observation? Okay, it's food for thought. I changed it last night because this is a symposium on myelopathy. I wanted to make sure she was myelopathic, but with that, thank you very much.
I think Jeff's case highlights the fact that the imaging is really helpful, but it's also kind of the clinical scenario. And I think with the case that Jeff highlighted, as Jeff Wilson has indicated, initial non-operative management doesn't necessarily mean the patient's not going to require surgery. I mean that's a pretty scary looking MR. So JJ, you had a comment, and then we'll go to the floor.
Just a quick comment, and I want Jefferson to actually comment on that. I had the exact same patient that Jeff presented with, and a patient presented to another physician, and the physician told her, either you have the operation, you're going to go paralyzed if you fall or do something. And it's not the first time. I'm sure many of you have seen the same scenario, where you see somebody with minimal symptoms just like this, and then they're told they're going to go paralyzed if they don't have an operation. So Jefferson, can you address that? Because I saw a couple of papers that you had that kind of addressed the trauma situation.
Yeah, I mean, we hear this a lot, and I don't think that the doctor that told them that is, lying or acting in bad faith. And, there is some concern. The studies suggest that the risk is low, but, we have to counterbalance that with our clinical experiences that we see patients coming in with, narrow spinal canals and central cord syndrome all the time. And presumably those patients may have had some mild symptoms before the fall. So I don't think we can say the risk is zero. I just don't think that we can say that surgery is justified in those patients to obviate the chance of a spinal cord injury down the road.
From the floor. Michael.
Michael Gerling from New York. I think this is an awesome symposium because, obviously that this is one of the difficult decisions we all face. A lot of these decisions are straightforward with more moderate and severe disease. But a comment and then a question. First of all, I was impressed, Michael, that you seem to feel that the SF-36 is helpful to you. Because in my population in New York City, I feel like they have so many other things whenever they present to me that would confound the results of an SF-36. And maybe to track them over time, and if they say, well, everything else has not changed, and then you're trying to follow them over time, I could see that. But I just feel like it's so abstract. And so I appreciate the fact that we're looking for other more sensitive tools to try and follow these patients and sort of tease out which ones would benefit more from surgery. But the question I have, and Jeff Wilson in particular, I thought great talk. Some of my patients have had numbness in their hand for a month, and then some of them have had numbness in their hands for 8 months. So for 1 month, if I follow them for 6 months, they're still not at the 8-month point. So how long do you think it's reasonable to follow a person that has numbness in their hand? I don't want to have numbness in my hand, and it distracts me, especially if it's my dominant hand. So these symptoms may seem mild in the big picture of things, but they do seem like they're very distracting and disturbing to people. And then in the context of the fact that you're waiting for things to progress or get worse, and what do you tell your patients that have this mild numbness in their hand? They've had it for 6 months, and the statistic that about half of them over the course of 3 to 6 years are going to get worse. Do you tell them that, well, if you get worse and I do surgery on you, you're going to go back to where you would be if I did your surgery today? Or how do you counsel them in that regard?
Yeah, it's a difficult scenario. I think the conversation is different for different patients. And all is to say, I don't think operating on any of these patients is wrong. I think it's a valid option. So if somebody comes with numbness in their hands and it's mild objectively, but it's bothersome to them, I think it's very reasonable to operate. I don't think we can say with certainty that numbness is definitely going to get better. The evidence does suggest that probably they will have some improvement in the symptoms, but likely not complete resolution. Some of them do. But, if you have that same situation in, say, a 70-year-old and they have numbness in the hand and it's been stable for a year, even if it's been stable for 6 months, I don't think it's wrong to watch and wait and see how things go. It's an individualized conversation for each person. I don't think there's a one-size-fits-all advice for what you're asking. I think, though, that the thing that concerns me a lot is when somebody comes in and says they had numbness in their thumb 3 months ago, and now 2 months ago they have numbness in their whole hand, and now the numbness is proceeding up the arm. And even though they're an MJOA 16, 17, that pattern of progression worries me, and I would recommend surgery for that person. So it's more so the progression of things over time rather than the symptoms in isolation.
Yeah, and I think that, the key, and, I take what your point, with regard to the limitations of PROMs, that people have got a lot of other comorbidities. That's fair enough. But, say with the case that you're talking about, I think the point is that to one person, it might not matter that their hand's numb. To somebody else, it might matter a lot. And you can ask them, how concerned are you about it? And I think if the patient is really concerned, and I think if they feel that's limiting them, then I think that is a very reasonable option to proceed with surgery. So that's what it's kind of getting at with the individualizing the treatment. And I'm not here to sell the SF-36. Obviously, all PROMs have got their limitations, etc. David.
But I'm sorry, just before you go on though, but just the most important thing about the answer for me is, what do you tell them about if they do get worse, whether or not they will have subsequent resolution with surgery? In other words, what is that was the most important thing I wanted to get to, is what is their prognosis if they get worse, with surgery thereafter?
Okay, maybe a brief response, Jeff?
Yeah, I don't think we know for sure. I think that some people will get back to where they're better than they were before. Some people will be normal, but some won't. So I don't think we can state in absolute terms with respect to that question. Some may get better, some may not. And it's hard to predict, where they'll fall on that continuum.
On average, 70% of patients will report that the improvements meet kind of what they determine to be functionally significant. Okay, so not everybody, but the majority.
And there are also studies that show that your patient satisfaction with their outcomes are different or worse if the symptoms have progressed before they had surgery. So that's another concern. Anyway, just a comment.
Okay. I think just one other point, though, is, we know even, a lot of patients with myelopathy and surgery do well, but we also know about 30% of them don't do well with surgery.
Yep.
That, they have neck pain, impaired quality of life. So you have to counterbalance the argument with that. Just because we do surgery doesn't mean you're going to do great, which is another point.
All right. I think we should move on. Okay, David Chan from Hong Kong.
Hi. Thank you. It's a great symposium. It's interesting to see JOA was not mentioned in the assessment panel because for myelopathy, especially like in Japan or Korea or in Hong Kong, we are still using the JOA score. And it's very sensitive in picking up those patients with once they can't use the chopsticks or like bundling, and they start using the spoon or the forks, then we know this is very sensitive in picking up those group of patients. So I know this C-Spine Research Society. Do you think in the long run JOA is still part of the assessment panel?
Do you want to maybe comment, JJ, and then Alan?
Yeah, I did mention it in my talk, just brought up the MJOA. I think it has clearly indication for patients with myelopathy and support its use. I think in milder forms it may have limitations. In moderate to severe, its application is better. But yeah, as I presented, yes, it's a valuable tool.
Thank you. Thank you.
Yeah. Okay, question over here.
Yes, Fred Harrington from New York. I just have an observation. I've had a few patients over the years who present with an anterior spinal artery type syndrome without trauma. And what that suggests to me that maybe the vascular hypothesis here is something we maybe should spend a little more time on. Should we develop some blood flow measurement, some quantitative blood flow measurement type of technology for this problem?
Yeah, it's a great question. There's a number of groups that have done that already. I think Langston Hawley's group at UCLA has done a study on that using dynamic contrast enhanced MRI to look at perfusion of the cord and look at perfusion deficits. I know I was trying to get that going, and we were also looking, there's a couple PET studies that look at perfusion and metabolism, but the work's early and more needs to be done for sure. There likely is a hypoperfusion effect in some patients, but not all patients. There's also dynamic trauma and other factors. So, but I think it's an important consideration that hasn't been really worked out yet.
The other part of the vascular piece is also the venous side and the blood spinal cord barrier, because we probably should be thinking a bit more about chronic disruption of the blood spinal cord barrier, because some of the inflammatory consequences of that might increase risk, for example, delayed C5 palsy, and those sorts of issues.
I'm actually reviewing a paper right now on disruption of blood spinal cord.
Very good. Question over here.
Yeah, Mohammed Maki, I'm one of the spine fellows at UCSF. A question for Dr. Feilings. You had said that patients who have cervical spondylolytic myelopathy do better with anterior approaches rather than posterior approaches. Are you speaking from anecdotal experience or from literature? And the second question was, you mentioned about pain. Is there any evidence to suggest that they do better from a myelopathy standpoint, or is it just from the pain? Thank you.
Yeah, so it wasn't for all comers with degenerative cervical myelopathy, because for all comers the evidence would kind of indicate that there's relative equipoise between anterior and posterior. So our studies, Zoe's trial recently. I was talking more about the mild myelopathy work, and so the evidence I very briefly presented. One of the papers using a machine learning approach and looking at the way patients cluster, In the mild myelopathy patients, the big driver often for surgery is pain. And they do appear to do better with the anterior approaches. And Jeff, if I'm not mistaken, I think you may have something similar to that you're working on. Maybe I'm thinking about some of our work that you're co-author on. Yeah.
Yeah, and I think actually it's a poster here. It looks at the combined AO data and specifically mild myelopathy, looking at trajectories of outcome over time. And again, about 30% have after surgery with mild myelopathy have a negative trajectory. Like they get worse over time. And some of the predictors, one of the predictors of that was actually posterior surgery.
Yeah. So just as a pearl, okay? So the evidence is emerging there with mild myelopathy. Okay, Jim Harrop, our president.
Jim Harrop from Philadelphia. Love the symposium. Real quick comment, and Dr. Moses' head might pop off when I say this, but I'll say it. Watching myelopathy patients for a long time, and I follow a lot of patients non-operatively, the neurologic exam is not static, meaning that you'll see a patient one day and you'll get an exam 3 months later and it'll be a different exam and it might be improved. I guess, one, I want you to comment on that. And two, most importantly to me is, how do you follow these patients? Because I usually don't see them for 6 months, and I have my own scenario what I tell them, but what do you guys tell them to look out for?
Who wants to handle that one?
True or false, Dr. Moses?
JJ?
Well, that's a really good question, but if I see the mild ones, I think moderate and severe, pretty much I will see them every 3 months for the first year, and I will follow them depending on how they do. After that, I may lengthen that, but I follow them every 3 months.
I can just...
Oh, sorry, go ahead,
Yeah.
Al. Yep.
So, Alan Martin at UC Davis, I'm running a prospective study where we're following these patients every 6 months and doing like a 1 hour long comprehensive assessment and trying to figure out what's relevant to follow. There's a number of muscle groups that we think deteriorate slowly, like hand grip, and we published that previously. So grip dynamometer is a good way to follow these patients. Hand intrinsics slowly get subtly worse. Their reflexes do change over time. Their gait is really important, so we're coming up with a measure that doesn't require the expensive equipment to try to watch their gait over time, tandem, and actually score it. But it's difficult. So I don't think everyone can spend an hour on each of these patients, but we're trying to come up with a 5 or 10 minute exam that can do that. So.
Very good. Question over here.
Sure. Damon Marr from the University of Kansas Medical Center, and also of note, recently completed time at the Texas Back Institute. Mike, this has been a phenomenal session. It's very informative. I had a comment for the diagnostic tools talk. We appreciate the shout out. Lieberman definitely appreciates his views being shared. And I kind of want to hopefully just share a comment of optimism that we're actively working on several, approaches to improving the ability to make objective measures available to like the daily practice. And honestly, the ability of what we carry in our pockets with our phones now is more than enough to achieve a lot of the metrics that we've already been working on. And a lot of this really has to do with refining our understanding of things like balance characteristics during sway, or sway characteristics during balance, and with things like simplified gait assessments. And so the bar to entry is much lower than it used to be, and it's quite accessible at this point. So just appreciate that.
Yeah, thanks. Yeah, I mean there's a lot of interest in potential smartphone applications to kind of assess movement and gait and so on. Okay, so very briefly, two last kind of brief questions or comments.
Bob Hart from Seattle. Mine is a comment, and I'll keep it very brief. I'm sitting here doing the math, and I realized that the first time I attended this meeting was now 25 years ago when I was a fellow, and that math staggers me. But the conclusion I want to bring out of it is I think nearly every year we have this debate, and nearly every year the conclusions are pretty much still the same as they were 25 years ago. And the vote on the cases is also pretty close to 50-50 every year. So I wanted to submit this topic as the operative definition of clinical equipoise. And with that, I'll turn the microphone over to Dr. Moses.
Dr. Moses.
Very quickly, regarding the gentleman who described a patient with numbness in a hand, if you have a hammer, everything looks like a nail. Just because they're seeing an orthopedic surgeon doesn't mean that the surgeon understands why the patient has a numb hand. It could be a carpal tunnel syndrome, a cubital tunnel syndrome, an asymmetric neuropathy. It could be either cord compression or root compression. You really have to work with a neurologist to define what you're dealing with. Assuming you get the correct answer and you do relieve the cause of the numbness, it may never go away because you may have irreparable cord, root, or peripheral nerve compression. But the comment, you have to understand what the patient is asking you to do. Can he or she live with it? It could even be cerebral for that matter. I really think a very careful neurological examination is important. Last but not least, you can't manage a patient based on statistics. The patient you may be seeing may be the one outlier with 99 others who are not the same. So you really have to define the problem before you can describe the treatment of it, if anything. Thank you.
Thank you, Dr. Moses. Points well taken. Careful exam and individualizing patient management for sure. So very brief final comment from Dr. Anderson.
Thank you. Paul Anderson from Madison. One clinical aid that was not mentioned is asking about falls. I have a special interest in osteoporosis, and orthopedic surgeons, neurosurgeons do not ask this question enough. 40% of people over the age of 65 before they have spine surgery have a fall. 40% after they have spine surgery have a fall. And I think we need to include fall assessment as part of this pre-op paradigm, especially in a myelopathic, because obviously risk factors are much higher.
Yeah, thank you. Point well taken. So I'm going to close out the symposium, and we can have further discussions over coffee. Thanks to everyone. Good job.